A very good day to everyone attending the 5th Asian Conference of Criminal and Operations Psychology. My name is Keng Chuan. I work as a consultant psychiatrist in Khoo Teck Hospital. I also go over to the Institute of Mental Health, Department of Forensic Psychiatry as a visiting consultant. Please pardon my voice, I'm just coming back from cold. My talk today is really about psychiatrists who can be involved in either a treatment or an assessment role, and how these two roles coming together could pose a conflict of interest that really should be best avoided. And finally, what we can do to try and avoid getting caught in such scenarios. So, like the presentation today, it's largely a matter of perspective. What you see is really dependent on what you look at the picture or the person that you work with in this context. And the lens that you look through really matters. So the picture can be both things at the same time, and like how the person you work with can either be a client or a patient, and what you actually see influences your ability to fulfill your duties accordingly. Now, there's a bit of background on myself to provide some context. So I've completed my basic medical degree and specialization training. This was completely in Singapore. I had 12 months in Melbourne for post-specialization training, and this offered me a bit of a balanced perspective between treatment and assessment. I was in a trauma recovery service, which handled trauma-related mental health conditions pertaining to first responders like military and the police. But that's another topic altogether. That's a treatment role. Forensic care, which is a statewide provider of forensic mental health services in Victoria. The state has treatment roles in the psychiatry hospital and prison services, but also assessment roles in the outpatient setting. It's important for us to use the appropriate terminology to identify the person whom we work with. It really sends the right message to yourself and to others in terms of your roles and responsibilities. Doctors are used to calling everyone as patients, so terming someone as a client might feel strange and foreign. But for this, we really need to consider the origin of these words. So a patient implies that someone is ill, unwell, they need to be cared for, to be looked after, and therein denotes a gradient of wellness. With doctor-patient relationship, there is a duty of care that is owed to the patient, and the doctor has to diagnose, treat, and offer advice with the patient's best interest in mind. Of course, there are exceptions to this, say in the interest of public safety. If someone has terrorist intentions, to violate the autonomy of such a patient would need to be done, but you could still see this as in the patient's best interest in that sense. Now, a client, on the other hand, is someone who is seeking services in the sense of cover. It's more like a customer who's here to buy a service or product. And in that sense, they will be on an equal footing with the service provider. And in such roles, there's a duty not to the client, but to court, to accurately advise court on matters at hand, how best to proceed in legal matters. And you could end up giving an opinion which might ultimately be unfavorable to the client, but that's what serves the court best at the time. I'm just going to raise a couple of scenarios where double heading can take place. One is where there's a patient whom you are working with, treating, and then the lawyers ask for a forensic report. And that actually works well from the legal perspective, because you know this patient over a longer period of time. You can give more informed deliberation and opinions. But there are repercussions to this, and I'll talk more about this a bit subsequently. The other scenario is where you'd see someone for an assessment, complete a forensic report for them, and then go on to treat them as a patient. And the trouble with this happens when you are later on asked to give evidence in court, because this means you have to doubt the patient, be skeptical about what you're told, and you might perhaps even be compelled to go into matters that were discussed with the patient in confidence to break this confidentiality. Now, in the medical setting, usually referrals come from medical sources. So that would include polyclinics, emergency departments, and other medical specialties. But the cases that I'm bringing forth towards today are cases that were referred by lawyers. So they have charges that might still be ongoing even at this time. They provided to allow for some context, but I've kept the cases very generic. It's more to discuss about the role of the psychiatrist in a treatment or assessment role rather than the case details itself. I'm going to start with a case in the treatment role, which I explained at the outset to this patient that I am not here to answer questions from his lawyers. So this middle-aged male came with charges that were pressed against him for having had upskirt photos and uploaded some nude pictures on the forum. So my focus really in a treatment role is what he needs here and now to get him better. So during the assessment, I would determine that there was no particular clinical needs that he had at this time. He doesn't need medicine, and we referred him to the counselor, but he had a very clear agenda, which was wanting to paint a picture of remorse and repentance and to depict how treatment was, so very helpful for him. And as a human being, of course, it's like no surprises, psychiatrists have emotions too. Sexual offenses, particularly on vulnerable victims, do tend to evoke a sense of anger and disgust. So I had to, push some of these emotions aside. But if any assessment had to be done, this would be the case as well. Even if I could, and I did carry out an assessment for him, which I did not, if the assessment turned out to be unfavorable, there is this concern that it would rupture the working relationship, any future treatment recommendations that I may have to make. He may not be as receptive to these. And the really hard question to ask is whether I would still be able to fulfill this duty of care to him in such a scenario. And of course, individuals do manifest with conditions like adjustment disorders or even major depressive disorder, which is termed as clinical depression. They do have prominent anxiety symptoms in response to looming prospects of being sentenced to jail, fines, whether these prospects are realistic or catastrophized. In the setting where media coverage is involved, there is potential for public embarrassment, or this may even have already occurred. So these are all very distressing scenarios, and it's really hard to treat these because there's no medication. These things go away. Essentially, it's very much supportive to get them through until resolution of the matter, which could drag on for months, years, and definitely have a substantial impact to an individual's functioning and the quality of life. So a clinician who's treating such a patient needs to be very much empathic and supportive to help them deal with underlying or even pre-existing problems that may have happened even before the offense. In that sort of a scenario, they wouldn't really be well placed in the right headspace to be a neutral assessor. This other case that I have is in an assessment role. It was a middle-aged male who was facing charges for domestic violence. He was very emotionally charged. You could tell he was distressed. He was breathing heavily. His eyes were closed when he was talking about his frustrations, how his partner had made various false accusations about him. And along the way, he specifically asked if I could help to treat him for the anxiety and the distress that he was going through. And this is actually quite trying for me as a doctor. In a helping profession, we're trained, we're wired to think in a way about how to treat and how to get patients better. And I really needed to hold back to keep such an instinct in check. Of course, in scenarios where there's danger or threat to life, sanctity to life is paramount. That has to come first. I wouldn't walk away from a client in any form of life-threatening scenarios. If they collapse, they need cardiopulmonary resuscitation, or there's imminent suicide or violent risks. These things need to be managed. There's a need to step out of the assessment role in the short term to deal with these. But if I were to do so much as just prescribe a single tablet of medication, in this case, it really changes the whole dynamics of the relationship. The client starts seeing me as someone who's here to help. And then if a report turns out to be unfavorable, then that's emotional betrayal of sorts of his trust. And from my perspective, taking on a treatment role, would that make me more sympathetic to him? Would it influence my objectivity? And would I try too hard to help? It undermines my credibility as a witness in this process. And it could potentially damage the clinician's professional standing. And it stems not out of any malicious intent to sway or mislead the court, but inherently it's out of well and truly wanting to help and do good. Only that it might end up helping the wrong party in this instance. So clinicians can really be caught in this sort of tug of war where your professional allegiance would truly lie. In the context of legal proceedings, the psychiatric inputs are either favorable or unfavorable. Favorable opinions could be seen as partisan, lose objectivity, and be deemed unhelpful to the court. Whereas an unfavorable opinion, you could lose the patient. The patient might not come back. Clinical care gets compromised, especially if the patient ends up feeling disillusioned with not just the one clinician, but healthcare providers as a whole, and they don't go on to seek help from others when they do need and could benefit from this treatment and help. I just want to share as well that the opinions I've been putting forth about not double-hatting is not just mine alone. It's backed by reputable international bodies, and it relates to psychiatrists practicing in the forensic role. So not just forensic psychiatrists per se, and the stance is really unequivocal in discouraging double-hatting. Finally, a bit about what clinicians, not just psychiatrists, but anyone working in a mental health role in a professional capacity with patients or clients, what could we do to try and avoid getting caught out by such scenarios? Specifying the role clearly, which is why I talked a lot about being clear whether you're working with a patient or a client and using the right terms throughout. It makes it clear to the patient or client whom you're working with, and it also serves as a reminder to self. You could let them know very clearly what you're here to do and what you're not here to do. But if they need help in those particular areas, how you can get that for them from someone else. Self-regulated checking in is also something that's very convenient, very accessible, easy to do. Just from time to time, again, asking yourself, is this a patient or is this a client? Am I doing right by this person whom I'm working with? And you could do it even in the midst of working with the person if the roles do have potential to get muddy. If in doubt, it never hurts to get another perspective. We all have our blind spots, so talking to a peer or a senior, can be done formally or informally. It's just useful to get that different perspective. So with that, I've pretty much come to the end of the presentation. Once again, apologies for the voice. It's really just, I hope you can hear and make out the stuff that I'm saying. I'm happy to take any questions if the circumstances do permit. Otherwise, I've left my email address there as well. So do feel free to write to me, to reach out to me, particularly if anyone you work with might need either treatment or a forensic assessment, though, as mentioned in this talk, ideally just not for me to do both as well. And that's the end of my presentation. I'm happy to hear if anyone has any queries or feedback. Thank you for your time.